Hello, everyone. So I'm Dr. Vineeta Ojha from India, and I'm a radiologist working in the Department of Cardiovascular Radiology and Interventional Radiology at the All India Institute of Medical Sciences, New Delhi. And today I'm honored to have with me Dr. Karolina Zareba, who is a cardiologist and a specialist in cardiac imaging, working in the Department of Cardiovascular Medicine. Department of Internal Medicine at the Ohio State University, and we'll be discussing mainly about the role of cardiac MRI in COVID infection. So, very warm welcome to you, Dr. Carolina.
Thank you so much. Thank you. I'm honored to be speaking with you and looking forward to our discussion today.
Yeah, thank you. So, coming to the topic, Dr. Zareba, COVID-19 has caused this unprecedented, global crisis, and we have seen so much of literature about, the cardiovascular implications of COVID-19 infection, and many studies regarding the role of cardiac MRI for diagnosing COVID-19 infection. So, in your personal experience and from what the existing literature or guidelines say. So what do you think, where does CMR stand in diagnosing, in prognosticating, or in overall clinical management of patients with active or recovered COVID-19 infection?
Yeah, that's a wonderful question. I think it's a question that we're all still learning the answers to. But I think over the last essentially year, we've all been very greatly impacted by COVID-19 in many different ways in the CMR world. Since its inception, we've known cardiovascular manifestations of COVID-19 infection are clearly apparent. We learned this early on, and we also, of course, given our superb tissue characterization with the cardiac MRI, it's really become the test of choice for looking at patients with active or convalescent COVID-19 infection and various presentations. I think one of the things that has helped, I think, all of us around the world is really the guidance from SCMR. And I have to say, really anything from the start of the pandemic, we had wonderful position statements on who to scan, when to scan, and how to do it safely. Really right from the beginning. We had the COVID preparedness toolkits that they provided us with, the initiation of the SCMR COVID registry as well, and then the case collections, which I think, we're all able to learn from. And I think these initiatives sort of really helped guide us in terms of how to use CMR in the COVID-19 pandemic and how to do it safely, but also how to really answer the clinical questions. I think we know COVID-19 has many different presentations. We know that, a nice paper just recently published from SCMR talked really about the various indications that patients are being referred for with, whether it's with active or convalescent COVID-19. We're talking about ventricular dysfunction, we're talking about myocarditis, pericarditis, we're talking about MINOCA, of course, with a large percentage of patients with troponin elevations, cardiac enzyme elevations, even with ongoing chest pain in patients who have recovered and are still having symptoms. I think the other things to think about are besides the acute coronary syndromes and stress cardiomyopathies that we might be seeing related to COVID-19, thinking about ventricular arrhythmias, vasculitides, thinking about how this affects the right ventricle with all of the pulmonary abnormalities that happen with COVID. So I think the breadth of what CMR can provide is impressive, and what information we can give within it. I think there are certainly protocols that are tailored for exactly what that indication or what the question or what the symptom the patient has. But I think the role of CMR in COVID-19 is growing and growing. I think there's certainly for many of the indications that I mentioned, there's certainly big roles with specific sequences and tailoring. But I think it's growing as we learn more of what COVID-19 can do. I think to answer your other part of the question about prognostication, I think this is exactly, we're getting to the time when I think we're going to be learning more. I think we here at Ohio State University are looking at this a little bit and looking at what really these ventricles look like after COVID-19 recovery, but quite some time after. So we're really starting to get to that time and see what will hopefully start rescanning these patients to see what their ventricles and what their hearts in general look like. So I think time will tell about that.
Yeah, yeah. Wow, that's a great answer. So, coming to my next question, Dr. Zareba, what in your experience are the most common imaging features of COVID-19 infection while doing MRI in such patients, and what are the imaging features that one must look for? So,
yeah, of course. Again, and this obviously depends a little bit on the presentation that the patient has. But I think the key parts to look at, of course, are looking at a variety of things. So one is of course looking at function. So has function been affected? It's wonderful to know the baseline function with whatever modality, but has function been affected? Left ventricular, right ventricular function, looking at volumes and function, and then really proceeding to that tissue characterization, which is going to be key. So looking at that parametric mapping if you have it, if not, looking at T2 weighted imaging, and really looking for myocardial edema inflammation. We know from old papers in just myocarditis before COVID even started that myocardial edema inflammation, even in just regular myocarditis, can last 3 to 6 months post CMR. So it's not necessarily we need to be scanning these patients on day 3 of their COVID infection. This will last. We will, unfortunately, this will last. So we have a little bit of time to scan them to sort of get these answers, okay? And so I think looking at myocardial edema inflammation, looking at parametric mapping to help with that. I think Lake Louise criteria is very helpful. Looking at the updated Lake Louise criteria, looking at what we actually do call myocarditis. I think we do have to keep looking for pericarditis, pericardial effusions, pericardial enhancement, and along with that. But I think the other aspect, of course, is tissue characterization with LGE and with gadolinium enhancement, and looking at not just your typical myocarditis patterns, but also looking at embolic phenomena, which can certainly happen with this prothrombotic state that COVID can cause, and also looking at you're thinking of Minoka patients, okay? These patients with this troponin elevation, what is it? Well, maybe their coronaries are fine, but COVID caused something, So I think all of these things, and using all the tools to really help you figure out what COVID caused in this patient, which can be very different from the last patient you saw the week prior in your CMR lab.
So my next question is about the role of mapping. So we have this larger series that was published by the group from Frankfurt, wherein they found, more than around 78% of the patients had T1 mapping abnormalities, and approximately 60% of them had T2 mapping abnormalities, and they found that they had the highest mapping had the highest discriminatory value for diagnosing COVID-19 infection, and they showed some correlation with troponins as well. But again, there was some debate regarding mapping abnormalities and their prognostic implications, because we do not have long-term studies yet regarding the clinical outcomes. So, but what in your experience is the role of mapping, and what is the use of mapping in patients with COVID-19?
With respect to COVID, I think the other thing to know that what we've seen, at least in our cohorts here, is you do have to really get a lot of slices. So, and what do I mean by that? We are getting not just one mid-short axis slice. We're getting some long axis slices to really know, because you may miss it if you just get one slice. It does not affect this ventricle in necessarily a diffuse pattern, but can certainly be localized in various areas. So, and I think, to your question about T1 mapping, I think that, professors Puntman and Ike Nagel, they really are experts in T1 mapping and authorities on this. And I think we know from theirs and many others research how prognostic T1 mapping can really be over time. So I think as T2 can resolve, when inflammation resolves, certainly T1 can change, but I think looking at the long-term prognostic value, I think T1 will actually help us more with that. Yeah. And looking at what interstitial expansion happens over time, and does this COVID-19 infection, however it manifests itself, well, does it actually over time cause interstitial fibrosis, expand the extracellular space, and cause issues down the road? So I think time will tell, but I think T1 mapping will really help with that.
Yeah. So I agree with you. So basically, so CMR is kind of, the diagnostic implications we have seen, but, a long-term effect and effect on the clinical outcomes of the patient, as well as the prognostic implications, is something that we all are waiting for. And only the next 1 or 2 years that research published would tell. So, so Dr. Zareba, so what would be your one take-home point for those listening to you today, and regarding the use of CMR in COVID-19?
Yeah, so I think, my take-home point, and this is sort of my take-home point for a lot of, I would say for the practice of CMR in general, I think is really personalizing the scan. So I think, one of my favorite aspects of CMR is really all the different sequences we have in our toolbox. And we have so many different things that we can use, these different sequences. But it really doesn't make sense to run, of course, a blanket CMR of all these different sequences in each patient. So I think really utilizing the right sequence for the right patient can really answer that clinical question, can really make a difference. And, I think the other aspect is sure, personalize the test to each patient, to each clinical question. And then I think really, while you're scanning the patient, adjust as you see fit as well. I think there's so many times when we're scanning the patient and we see things that we were surprised about, we didn't expect, and you end up completely shifting the exam a different way. So I think personalizing before, as you plan ahead for the exam, and during the exam, and tailoring it to really make the right exam for the patient, I think makes a difference in the patient care. And I think the same goes with the COVID CMR, because again, what you see, what the history you obtain is, because the presentation can be so varied. I think knowing what you, not just what they present with, but also what you see when they get on that table and saying, okay, well, we're going to change directions because this is totally different than what we expected. So I think just that's probably my one piece of advice that I think goes for most of CMR.
Yeah, true. So I completely agree. So thank you so much, Dr. Zareba. I mean, it was such a pleasure talking to you today. And, I wish that 2021 is better than for all of us than the last year gone by. And to those listening to us, please follow our social media hashtags, hashtag YCMR and hashtag SCMR 2021, and also do not forget to register for SCMR 2021, because as I hear, there is a lot of exciting content on the use of CMR in COVID, some of which we touched today, but a lot of new content that is going to be discussed throughout the scientific session. So we'll be seeing you there. Thank you so much, everyone.
Thank you so much.